Hey everybody, we're going to continue on with our discussion in the concept of perfusion, and this time we're going to focus on the exemplar of angina or angina. The objectives of this session are to discuss coronary artery disease, signs and symptoms related to angina or angina, chest pain, identify means in which it can be managed without medications. We're going to talk about some classes of drugs used to treat chest pain or angina. And then, of course, we're going to focus on some prototype drugs, as well as the nursing process and patient education. In this particular session, we are not going to focus on myocardial infarction as that comes later in the program. Coronary artery disease is one of the leading causes of death in the United States. This is a narrowing or occlusion of the coronary artery, and it can cause myocardial ischemia or infarction eventually and a potential MI. So it's really important to prevent coronary artery disease. Atherosclerosis is the most common etiology or cause of coronary artery disease, and this is the buildup of plaque in the vessels. Just a little bit about blood flow around the heart. The myocardium receives blood via the coronary arteries. These diverge into smaller branches around the heart, and these provide a continuous supply of oxygen and nutrients. Super important. When we're thinking about angina pectoris or just chest pain, we can call it that. It's acute and it's due to insufficient oxygen to the myocardium or that heart muscle. It accompanies physical exertion most times or emotional excitement, and it's increasing the myocardial oxygen demand. Some common symptoms that you might see with chest pain is a steady, intense pain in the anterior portion of the chest. Pain may radiate to the left shoulder, left arm, spine, jaw. Now, important to note are women don't manifest maybe the same way. For women, you might see gastric distress, nausea, vomiting, fatigue, sweating may be more common. So when you're thinking about genders and the classic, I'm having chest pain, please know that the female gender sometimes doesn't manifest the way that you would think would be a textbook classic presentation. Clients may state they have fear or a feel of impending doom. They may have pallor, dyspnea, diaphoresis, tachycardia, elevated blood pressure. The duration is usually short, and pain diminishes when physical rest or stress is reduced in some cases. So when we're talking about angina, we got to talk about stable versus unstable, and this is really important when you get later on down the road. Well, I mean, it's important in general, but sometimes we can have stable angina, and this is fairly predictable. It has a predictable frequency, a predictable intensity and duration. Stable can be relieved by rest. Now, when we start talking about unstable, this is when episodes start to occur more frequently. They're more intense. So there goes your predictability right out the window. And then now you could have pain at rest, which is never a good thing. Non-farm, you want to think always, teach your patients lifestyle changes, okay? The goal of everything that we do as nurses is to prevent. So what are some things that we want to do? Lifestyle. Of course, no alcohol. Let's get rid of those cigarettes. I need some kind of a diet here. Probably need to lose weight. Need to manage that blood pressure and diabetes and increase my exercise. When we're thinking about the farm side of the house, it's going to kind of do two things. Either reduce the intensity and frequency or reduce the myocardial demand on the heart. Ultimately, you want to terminate the acute episode and then slow the heart rate. Again, decrease that demand of oxygen for oxygen with the heart. Slow the heart rate, reduce the preload. Some may reduce contractility and lower the blood pressure, which is going to reduce the afterload. All right, so we're going to dive into one of the mainstays. If there's one med I say you're probably going to have memorized is your nitrates, commonly called nitroglycerin, nitrostat, nitrobid, many other names. These are going to relax both arterial and venous smooth muscle. What it does is it's going to dilate coronary arteries. It's going to reduce the workload of a heart. That's what we want. And it's going to lower the oxygen demand, the myocardial oxygen demand. That's exactly what we want. Now, it can be short acting, and that's going to terminate an acute episode, and long acting, that's going to decrease severity and frequency. So clients can take this in the moment to treat, or sometimes they can take it preventatively if they know, if they have stable angina, they know it's going to come, they can take it preemptively. It's the most widely used of the nitrates, and it can be delivered in a number of different ways. Very common, sublingual. It can also be taken PO. We can give it IV via drip on titration. That's going to be done probably in the ICU, most likely in the ICU setting. Transmucosal, topical, and then transdermal. Can also have patches. And then it does come in an extended release form. Again, you can take it during an acute episode that's in progress, or you can take it before physical activity if a client knows that's going to cause pain. When you give it sublingually, it really reaches its peak in about 2 to 4 minutes. And that's really, really important. We're going to talk more about that later. You need to know how to administer sublingual nitroglycerin. You also need to make sure we teach our patients, if the pain isn't relieved in about 15 minutes, they need to call 911, okay? The whole goal here is we're just talking about chest pain in general, but to plant a seed for you forward thinking about myocardial infarction and MIs, this is where the kicker comes is, if you have chest pain, you're taking nitro and it's not relieved, you have got to call 911 because we're most likely leading to a heart attack. When given IV, we need to make sure this medication is in a glass IV bottle, and it has special tubing for it because the plastic tubing that we use for IV will absorb the nitrates, and this is going to reduce the dose that goes to the patient, and we don't want that. We also need to make sure that if we're giving it IV, we cover that bottle because the light that gets exposed to it can also reduce the nitrates that will go to the patient. Specifically with transdermal, you always want to make sure that you have gloves on when you're taking off transdermal patches or applying them, because you don't want to administer nitrates to yourself as a nurse. So always make sure you have gloves on. Adverse effects, pretty common. Low blood pressure. Well, when we're having angina, our blood pressure will go up, so it's not uncommon that's going to happen. That can make clients dizzy. Headache is truly something that can come, especially if it's not pain related. Clients may feel like they have an overwhelming headache. You may see flushing of the face, and that's due to that vasodilation that's kind of happening. You want that to happen a little bit, and they may get a rash. Adverse effects are usually cardiovascular in nature, and they're rarely life-threatening. Because the nitroglycerin dilates cerebral vessels, you get that headache. It's very common. It may be severe. It's like the worst headache you ever had in your life. Occasionally, venous dilation caused by nitroglycerin can cause what's called a thing called reflex tachycardia. So they can go ahead and experience that. Some providers may prescribe a beta-adrenergic blocker to diminish some of the undesirable effects related to that reflex tachycardia. Most clients will say that nitroglycerin side effects will diminish after a few doses. We do need to think about contraindications with nitro. It should not be given to patients with pre-existing hypotension. Okay, we already know it's going to cause low blood pressure, so if they're already hypotensive, that they can't take this medication. And if they have intracranial pressure or head trauma, remember, some of those cerebral vessels, they're going to get dilated, so you don't want to have that. This drug is contraindicated in what's called pericardial tamponade or constrictive pericarditis. I know you're not familiar with that yet, but you will be. So when you get to that point, these are clear contraindications. In the sustained release form, it should not be given to patients that have glaucoma because that's going to increase intraocular pressure. If a client is already dehydrated or hypovolemic, you need to correct the dehydration and the hypovolemia first. Otherwise, if you give nitro, then they're going to be in severe hypotension, which then can lead itself to shock. There are drug-drug interactions with nitro. So if your client is on Viagra or Cialis or one of those other medications that treat erectile dysfunction, they should not take nitro. Okay, this is going to cause severe life-threatening hypotension and cardiovascular collapse, and ultimately could lead to death. So one of the things you need to ask your patients, especially your male patients, are you on any of these medications? And a lot of times maybe they don't want to say that they're on those, but we really need to get that, because this could be absolutely 100% life-threatening. As always, decrease the alcohol, and if there's any antihypertensives on board, it's just going to potentiate potential problems with hypotension. There are some concerns, lab tests that you need to do. You're not too familiar with these, I don't think, of as yet, but they're specific for this, and this is the value of urinary catecholamines and a thing called vanilla-mellitic acid. I just call it VMA. Those would be specific for this medication. Herbal-wise, hawthorn, this particular herbal medicine can cause hypotension. Again, we don't really want severely low hypotension. Treatment for overdose can be administration of normal saline boluses. So one specific med we're going to talk about now, because it does help with chest pain, but it also helps with hypertension. So we're kind of getting some of these knocked out of the way before we really dive into hypertension. But this is Cardizem, and this is a calcium channel blocker. This is going to inhibit the transport of calcium into those myocardial cells. It's going to relax arteriolar smooth muscle. It's going to reduce the cardiac workload, and it's going to bring more oxygen into the myocardium, which is exactly what we want. This inhibits transport of calcium into the myocardial cells. It has the ability to relax both coronary and peripheral blood vessels, ultimately bringing more oxygen in and reducing cardiac workload. It's useful predominantly in the treatment of atrial dysrhythmias, which you don't have yet, but just know that it exists, and hypertension, as well as angina or angina. It can be available in IV route and administered as extended release. Again, if you're giving extended release, don't crush or chew, and usually if you're doing XR meds, extended release, those are going to be once daily, which is kind of nice for the patient, because if the less amount of times they have to remember to take medications, that's really going to help with compliance. For administration alerts, we need to be considerate with IV administration. Your patient should continuously be monitored, vital signs, EKG, telemetry. And with this particular medication, you need to understand, and I know you don't know what it is yet, we're not going to go too deep into it, but cardioversion equipment must be available. So if we're going to give Cardizem IV push, is typically what could happen. There are specific protocols, and you have to be able to be ready to cardiovert the client, or the provider to cardiovert the client. So we'll talk more about that in a later course. Adverse effects: low blood pressure, hypotension, bradycardia, heart failure, can cause constipation, headaches, dizziness, and edema. Typically, effects are not serious, and they're typically related to vasodilation. So here comes that headache again, and that dizziness, edema of the ankles and feet, and abrupt withdrawal can precipitate acute angina. Specific contraindications, we need to be careful. It's contraindicated with patients with what's called an AV heart block, sick sinus syndrome, severe hypotension, a bleeding aneurysm, and those undergoing intracranial surgery. So those all kind of come back. I know you don't know heart blocks yet, but if there's a block in the heart, well, we don't want to stop that conduction, and calcium channel blockers kind of help a little bit with that. Hypotension, severe hypotension, that just makes good common sense. A bleeding aneurysm or intracranial surgery. Remember, this medication could help with dilation a little bit, so those are going to put our clients at risk for complication. And as always, contraindicated with severe renal or hepatic impairment. There are some drug-drug interactions, Cardizem with other cardiovascular drugs, especially, guess what, digoxin, guess what, beta-adrenergic blockers, or if a client's in a complete heart block, which is really bad, if they have heart failure or dysrhythmias, this can increase stage levels. It could make clients become severely hypotensive, especially with the beta blockers or other antihypertensives. So you just need to be aware of that, so you can manage that. When we start talking about really severe renal failure patients later on down in the program, it's not uncommon to see them on all of these. Cardizem and dantrolene, I think I said that right. Oh my gosh, should never be in combination because that could cause cardiovascular collapse. Lab tests are listed as unknown. There is some herbal, and goodness gracious, St. John's wort, here it comes again. Ginseng, back again. This is going to decrease the effect of the Cardizem, so you don't want to have clients on that. Garlic, hawthorn, and golden seal can increase the antihypertensive effect of Cardizem. If an overdose is needed, a medication called atropine will be used to reverse bradycardia and the overdose. Hypotension can also be reversed by a vasopressor, such as dopamine and dobutamine that we presented last time. And clients can receive calcium chloride by IV slow push to reverse hypotension, or heart block induced by calcium channel blockers. When we're considering the nursing process, we always need to make sure that we monitor the patient's condition, provide education. Vital signs, very important. EKG monitoring. We need to make sure that we have a full history, lifestyle, current drugs, and that's really, really important. Nitrates and calcium channel blockers. Their dietary habits, make sure we talk about that, get that under control. And pain, we've got to ask about the type, the place, the severity, the duration, what brings it on, what doesn't bring it on, how does it go away, does it not go away? You have to ask all of those questions and collect subjective and objective data. Again, any meds that they're on, we need to have a complete med history and do a complete medication reconciliation. Some nursing diagnoses for these medications would be decreased cardiac output, no surprise there, deficient knowledge regarding their condition and or pharmacological treatments, and risk for falls related to adverse drug effects. So when you think about diagnoses and possibly prioritizing, it's all going to depend on what's happening with the patient at that time. But please don't think that at-risk diagnoses cannot have a higher priority level with your nursing care. Ultimately, with those diagnoses, we want clients to have goals and expected outcomes, and we want them to reach them. That's the whole reason why we're doing what we do. You want clients to be able to explain angina, be able to verbalize, the ability to follow their prescribed medications. Those are two common ones. When we're thinking about our nursing interventions or implementation, we want to encourage compliance with their medications and provide any additional education as needed. Evaluation, ultimately, did your plan of care work or not work? When we're talking about chest pain, ultimately, we want to be free from any pain, or reduce the frequency or episodes, or prevent a myocardial infarction. And always think, again, this is really, really important. Clients have to be very knowledgeable about their medications, and they need to take these medications. So when we're doing teaching and education, we're going to look a little bit about nitrates just to begin with. Again, monitor your blood pressure. Teach them how to do that. We talked about that in the last session. They need to know that IV nitrates have the greatest risk for severe hypotension. Now, they're not going to give IV at home, but that'll be in the hospital. Educate your patients that alcohol needs to be discontinued, of course, the smoking, and really hone in on that Viagra and Cialis. If they become hypotensive, then they should not take nitrates. So if I have nitroglycerin at home that I can take every 5 minutes for 15 minutes for chest pain, but if my blood pressure is already in the toilet, then, I don't want to take that medication. So this leads you to, we're going to talk a little bit about how to administer, what clients need to know, and when to call 911. And this would be if the chest pain is not relieved. For calcium channel blockers, again, assess vital signs, watch for hypotension, hold the medication if the blood pressure is low or the heart rate is 60 or below. They want to also know how to do orthostatic blood pressures because they can cause dizziness. So we need to talk to our patients about how to do one. You do one lying down, then you shift and you sit and you get another blood pressure and then you stand. We'll also do that in the clinic setting. For calcium channel blockers, we need to assess for signs of heart failure, left and right. Daily weights, we already talked about those, and assess for bowel functions. Again, teach your clients to self-monitor their blood pressure and pulse. They want to be mindful not to take aspirin unless it's completely ordered by the physician. And again, no erectile dysfunction meds. Proper use of nitro. So let's just talk about this. One, nitroglycerin, especially sublingual, needs to be in a glass bottle, just like it does when you're giving it IV. It needs to be a dark bottle because we don't want that light, remember? How they get administered is the client may take one sublingual tablet every 5 minutes up to 15 minutes, or 3 doses. If they don't have chest pain at that time, they need to immediately call 911. They do not want to drive themselves to the hospital because what's going to happen is EMS is going to come and they are immediately going to do a 12-lead EKG to see if they are having what's called a STEMI, which is indicative of a myocardial infarction, and that's going to change exactly where that patient goes and how they get treated if that's the case. Transdermal, nitroglycerin can be given transdermally in patches or paste. So what you need to teach patients is where to apply those patches. You'll definitely want to take a look at that, and that they should always remove the previous patch or paste prior to putting on the new one. Nutrition is always super important. We're talking about cardiac, we're talking about perfusion. It's not too much of a leap to think, guess what kind of nutrition do we need? Low sodium diet, low fat, no alcohol, no smoking. Lifestyle changes, yes, we want to lose weight, increase exercise, manage hypertension, and manage diabetes, if not eliminating both of those. You should also tell your client what to do if they get dizzy. So for example, if they feel dizzy, they need to stay in maybe a seated position for a minute, wait for their body to adjust, and then stand up, see how they feel, and then wait for a minute before they start walking. And as always, this is in an effort to prevent knowledge deficit. If you have any questions regarding this presentation, please post your questions in the Prep for Exam 3 forum, and I look forward to seeing your questions. Have a great day.